Okay, so we'll talk about assessments of the skin. I think we've done a lot of this already just in the first half hour of this module, so I think it's going to go pretty fast. Okay, so let's carry on from here. Okay, so just a bit of anatomy as a reminder here. So the skin is the largest organ of your body. Okay, the liver is large, so the liver would be considered the largest internal organ of your body, but the skin's the largest overall organ. Okay. What's the function of the skin? Well, it's for protection from the environment. It's for sensation, since it has lots of nerve fibers, so you know what's touching you. Fluid balance. Without the skin, you'd lose tremendous amounts of fluid and electrolytes. Temperature regulation, for sure, by vasoconstricting or vasodilating. You can either keep the temperature, the core temperature of the body, or you can release temperature. Okay. Um, well, under protection is where it's protecting you from not only the environment, like the elements, but from bacteria, viruses, funguses that would love to invade your body. Okay. Look at the structures. So the epidermis actually doesn't have too much in it, right? It's actually an avascular part of the skin. There's no blood vessels going to the epidermis. In fact, oxygen diffuses from the dermis to get into the epidermal cells. Okay, so most of the action is happening in the dermis, where you have your hair follicles, you have blood supply, so capillaries, little venules, you have sweat glands, you've got sebaceous glands that are attached to the hair follicle, you have what are called eccrine sweat glands, which can control temperature. Why? Because they can release sweat, and sweat can release heat with it, right? The sebaceous glands are more for lubrication of the hair follicle, as opposed to eccrine sweat glands, which are more to release fluid and heat. Okay, you have nerve endings for sensation. Most of the action is taking place in the dermis. Okay, so that's why superficial burns of the epidermis only heal really well. Okay, compared to deeper burns, I know I'm going off topic here, but deeper burns can really damage nerves, blood vessels, hair follicles, because the heat has been transmitted into the dermis. That will be for another time, though. I think this slide is self-explanatory. I'm not going to spend any time on this, so that I'm trying to keep to a certain number of hours. So just look over the slide. I think it's pretty straightforward. Okay, so normal changes of the skin. Well, as we age, our thin gets much, our skin gets much thinner, right? So, and it gets much looser too on the surfaces of our body, right? We start to get many more pigmentary changes that aren't necessarily harmful. They're just from solar pigmentation, but they're not harmful. They're actually called aging spots. Okay. There's more wrinkles, skin folds, loss of elasticity. So if you were to pinch the skin of an elderly person, um, uh, and tent the skin, it wouldn't just recoil quickly compared to a child or a young adult, where it just recoils really quickly. Okay. Diminished hair growth because there's diminished blood supply, right? The hair follicles need blood supply, so there'll be less hair. The skin is much more fragile and thin. Older patients get skin tears all the time from minor injury. Um, they scrape their arm on the side of a door, and suddenly they've got this huge skin tear that's folded over on itself that needs to be put back together. Okay, so very, very thin skin and fragile. And often there's bruising to their skin as well from minor injury. And because of all of these things happening, they have a much reduced ability to heal. Their immune system is not as robust as it used to be, And on top of that, there's less blood supply to the skin, and there's just overall less healing ability of the skin. Okay, so let's just go over a couple of terms here. And some of them will be, you will have heard of them before, but erythema is just a term for redness. So if there's a rash that's red, erythematous. That's all it means, okay? Nothing else. Cyanosis is bottom right here. Well, cyanosis means that there's deoxygenated blood in the circulation. Okay, so peripheral cyanosis, such as in this image of the hand, well, that could just be from something of the hand, such as Raynaud's disease, where you have vasospasm of the arteries, leading to pale fingers, and then once the arteries start to vasodilate, you can get purplish-looking fingers. If you have central cyanosis, so purple lips, or purple skin of the core of the body, well, that's really different. That's usually coming from the lungs or the heart. There's some kind of problem where you're not oxygenating your blood properly, okay? Jaundice in the first image here, well, that's what's called scleral icterus, and it's yellowing of the eyes from bilirubin, right? The breakdown product of red blood cells. And bilirubin is typically processed in the liver and then excreted in the bile. So if there's an issue with excessive red blood cell breakdown in your body called hemolysis, or the liver's not functioning properly, such as in hepatitis or cirrhosis, you can develop jaundice. Okay. Pruritus is purely just a term for itchiness. Okay. In fact, a lot of people with jaundice are itchy because bilirubin gets into the skin and it's irritating to the skin. So a lot of people with liver failure, for example, complain of very itchy skin. Okay, because of the bilirubin that's deposited within the skin itself. But pruritus in itself is just a term saying itchiness. That's it. Ecchymosis, just a term saying bruise. Image number 2 is an ecchymosis. That's it. Okay, there's nothing else to it. There's no image of petechiae, but what are petechiae? Those are those little tiny red areas of the skin. They look like little red pin dots everywhere, and that's from typically low platelets or poorly functioning platelets because somebody, say, is on aspirin or clopidogrel. Okay, so thrombocytopenia or poorly functioning platelets can cause petechiae. Okay, and of course they're non-blanching because it's blood outside of the capillary. Image number 4 is just showing you that as you rub across red inflamed tissue, to ask, is the blood in the tissue or is it in the blood vessel? Well, if it blanches and you're moving the blood away because it's in the blood vessel and it'll return, well, that's a blanchable rash. The redness is coming from inflammation, but the blood is still in the blood vessels. Non-blanchable rashes, like in image 2, that ecchymosis or petechiae, they're not going to blanch. The blood is in the tissue. Okay, so you're not going to get rid of it by pressing it. Okay. Okay, so primary skin lesions and characterizing them. So a macule, so top left, a macule is just a flat area of the skin. So it could be a rash or a freckle or some kind of staining of the skin, but there's nothing raised. So if you were to close your eyes and run your hand over it, you'd never know it was there. Okay, that's a macule. Okay, let's go to the bottom left, a papule. So a papule is basically just a raised lesion, small though. So a wart could be a papule. Acne could have papules, just raised red lesions. What else could have a papule? Psoriasis, we usually reserve the term plaque for psoriasis. It's bigger than a papule, and it's raised above the surface. So in the image here, you'll see those silvery plaques of psoriasis. Okay, so just think of a macule as flat on the skin, a papule is raised above the level of the skin. You can feel it with your fingers. A vesicle is fluid filled. So the classic vesicle is herpes zoster, which is shingles, or herpes simplex 1 or 2. Those are viral infections, and they create vesicles, those fluid-filled vesicles, that we can actually cut open and take a sample and send it for a viral culture, or it's called a tank smear, okay, for viral infections. A bulla is just a bigger blister, or a bigger vesicle. So instead of these being these little clusters, it's just bigger. Okay, it's fluid filled and it's bigger. A wheal is an allergic reaction. So they're typically from insect bites, and what are they? They're just inflamed tissue that cells and inflammation have come to because of the insect bite or allergic reaction, for example, of the skin. And it's a raised area, so a raised white area with redness around it, and we call it a wheal and flare reaction. Okay, so the wheal is the center part that's raised, and the flare is the redness around it. Okay, so a nodule is just bigger than a papule. They're typically solid, so you could have nodular acne, right? You could have papular acne, smaller lesions. Nodules are bigger. Cancers can be nodular on the skin. Okay, they're solid, and they're bigger than just a papule. Okay, a lipoma, what is it? It's just a benign. It's just a benign tumor that's made up of fat. So sometimes patients will have lipomas on their tissue, and we just reassure them that they're just lipomas, they're harmless. Okay. A cyst is fluid filled. Okay. Bigger than a papule. So cystic lesions can sometimes need to be drained, such as a sebaceous cyst, which is a fluid-filled sac from sebum, which is supposed to be draining into your hair follicle. Well, it got blocked, and it formed a sebaceous cyst. And sometimes we have to open those up and drain them, or just completely remove them. Okay, pustule, pus-filled lesion. Okay, so they're usually small, otherwise we'd call them an abscess. If they were large, we'd call them an abscess. Pustules, a pustular rash is typically something like acne. And in this image, might be hard. Oh, you might see a couple of pustules. So white areas with red around them, and there's a little bit of pus within the sac. So secondary skin lesions are usually what's happened and altered the primary lesion. So say, for example, someone has scratched a really itchy rash. Well, it's not going to look the same anymore. There's scratch marks on it, they've dug into it, and they may have caused a lot of skin erosions, which makes it really hard to diagnose what the underlying skin rash used to be, right? Because it has secondary skin changes. Scarring can be a secondary skin changes. So say you had a laceration after you fell off your bike and it didn't heal well, and you're left with a scar. Okay. Ulcers can be secondary skin lesions. So the initial skin lesion may have been just a bit of erythema to the skin because of the pressure on the area, and then the skin started to break down and you developed a pressure ulcer. Okay. Hypertrophied skin. So let's say you had a laceration, and Sometimes in laceration, especially in black people, um, the skin keeps on trying to heal and causes excessive tissue, which is called a keloid. So instead of healing flat again, the body didn't stop. It continued making more and more scar tissue, and you'll see this in patients, and they're called keloids. And they're hard to treat because if you were to try and remove it, well, you're removing scar tissue, and it may just form another keloid. Okay, so sometimes we inject them with steroids to try and shrink them. Sometimes we'll use steroid creams on them to try and shrink them, but they're not always that easy to treat. So think of a keloid as the body just tried to heal, but it overhealed. It went overboard. Okay. Okay, so what's a fissure? Cracked skin. So you could have dry skin of eczema, and if you have cracks in it, we'll call it fissured. That's it. What's atrophy? It's thinning of the skin. What can cause thinning of the skin? Well, old age or frequent use of cortisone creams will thin the skin. Okay, and if we use cortisone creams a lot on skin, we'll thin it so much that you'll start to see the underlying blood vessels. So we're super careful with cortisone creams on the face for a long time because of the thinning and the atrophy of the skin. Scales, typically just dry skin that's just falling off. So the epidermis is just sloughing off. So dandruff can be an example of having scales that are just fluffing off. The top of psoriasis plaques has a silvery scale that can sometimes fall off. So that's all it means. Just sometimes fungal infections will have scales and dry skin on top that's just sloughing off. That's all that means. Okay. Some patients have extremely dry skin, especially in the winter. And this image on the right there reminds me of that. Really dehydrated skin. And we just apply frequent moisturizers to that. Okay. It's more frequent in the winter because of the dry air. Okay, so that patient looks like he needs a lot of moisturizer to that skin. Okay, so crusty lesions. Well, the classic crusty lesion is impetigo. Okay, I mean crustiness can occur from anything because basically the crusting is just from the liquid that leaked out of the infection and then crusted on the skin. But the classic rash that has crusting and honeycombing, it's called, is impetigo. But you can get crusting, say, with a cold sore, where the liquid breaks open from the vesicle and then causes crusting on the skin. Okay. The next one is lichenification, and all this means is just over time, because of the dry, scaly skin and scratching at it, the skin has thickened. Okay, and it's what we call lichenified. That's all it means. Thickened skin. In fact, I would say the most common cause of lichenification is having some kind of chronic skin condition that you've scratched and rubbed for months and years, and the skin has responded by becoming thick. Okay, thick and leathery. Okay, so let's talk about the nails a bit. So the nails are typically flatly adhered to the nail bed, right? And when there's nail changes, sometimes it can help us diagnose the underlying condition elsewhere. Okay, so let's go through this a bit. So spooning of the nail, it just kind of looks like your nails like dipping down and looking like a spoon. And that can be classic in iron deficiency anemia. Okay, so low iron states where you're anemic because your bone marrow cannot make proper sized red blood cells, and you can get spooning of the nails. Bose lines are just lines that go right across a nail. It's almost like a ridge in the nail. And that's usually occurred because there's been some kind of either severe illness or stressor. Sometimes a massive stress to someone can cause a bowline. Or there's been some kind of direct hit to the nail, and where the nail grows, which is under the cuticle, it's been disrupted a bit, and when it grows out, it grows out with a Bose line. So think of Bose lines as either severe illness in the body, or there's been some kind of local injury to the nail matrix under the cuticle. Okay. Paronychia is actually not a nail condition. It's an infection of the tissue around the nail. So the cuticle and all around the nail, and it's filled with pus, right? So typically we need to freeze the finger for that and actually put a scalpel into the paronychia and drain the pus out. That's really the treatment for paronychia. Clubbing is an interesting condition where um, the the skin and the nail change shape at the end of the fingers, and they actually look like little clubs. Okay, so and what can cause clubbing? So anything that causes chronic hypoxia can lead, or hypoxemia can lead to clubbing. Okay, so typically it's going to be lung and heart problems. So for example, cystic fibrosis, lung cancer um, can cause clubbing. Congenital heart diseases, where there's chronic hypoxemia. So any kind of cyanotic heart disease can cause clubbing. Okay. There are some other causes like inflammatory bowel diseases such as Crohn's disease and ulcerative colitis. But typically for clubbing of the fingers, think of anything that causes chronic hypoxemia. So it's going to be respiratory and congenital cardiac issues. Pitting of the nails, these little pits all in the nails, when we see that, we think of psoriasis. Okay. Patients with psoriasis can sometimes start off with pitting of the nails and then develop the plaques of psoriasis. Okay. Okay, so I'm not going to spend too much time on this slide. Assessment of hair. Let's just go through a couple of things. So albinism is a genetically inherited disease with absence of pigment to the skin. So you can imagine with absence of pigment, meaning the melanin, these patients can be very prone to solar damage and skin cancers because of the lack of protection from melanin in the skin. Okay. Alopecia. Well, let's talk about male pattern baldness. So male pattern baldness is from the hormone testosterone, and it creates a very typical type of balding that you can see in the image to the right. Okay. Um, alopecia. So alopecia, what's called alopecia areata, is just a focal loss of hair. So it's an autoimmune disease, and it's almost like having a circular little area on your scalp, say, where you've lost the hair. Sometimes it'll grow back, sometimes it won't. Um, Often we'll try injections of corticosteroids into the bald scalp that's missing its hair to see if we can stop the autoimmune disease and hopefully allow the hair to grow back. Alopecia totalis is complete loss of hair throughout your entire body, and often that doesn't come back. So it's hair, eyebrows, um, all of your skin, pubic hair, all lost. Okay. Okay, so let's talk about some diagnostic procedures on the skin. I know at the top of this module I went through them really quickly just to give an overview, which I think is helpful because then you get to hear it twice. Sometimes you need to listen to something 4, 5, 6 times before it sinks in, and repetition is really the key to receiving a lot of information. Okay, so let's move on here. Okay, so patch testing, well, that's basically skin testing for looking for allergens. So someone comes in with urticaria, which is kind of a diffuse, itchy, allergic rash to the body, and we can't find the cause. Right? They're not on a medication. They don't seem to have received an insect bite, and they just have ongoing urticaria. And so we can send them for what's called patch testing, skin patch testing, and they get injected with all kinds of allergens that are labeled, and the response to the skin is assessed, right? So if there's absolutely no response, okay, you're not sensitive to that allergen. All the way up to, do you have a significant red raised area from a particular allergen? So that's what skin testing is. Diascopy we've spoken about, that's just whether your skin blanches or not. Culture and sensitivity we've spoken about in terms of culturing bacteria, making sure that you get a good sample with a Q-tip right into the pus, not just taking a skin, like a skin sample, which is going to result in not a very useful sample. Sensitivity is when you get the report back about which bacteria it is, it'll tell you what antibiotics it's sensitive to, right? Which can be really helpful in, say, MRSA, where we've taken a swab of the skin with this pus, and then we get a report back saying, what is this bacteria sensitive to? Skin scrapings are typically done for fungi, right? We can send them to the lab for culture, or we can put them in potassium hydroxide and look at them under the microscope. Okay, and that's the next one, potassium hydroxide. The tank smear we've spoken about, that's to diagnose viruses that are still in the blister, and we what's called unroof the blister, and we take a sample of the fluid. Wood light examination is done in the dark, and you basically just fluoresce the skin, looking at the rash, looking for infection. Okay, so skin biopsies we've done. So shave biopsy is just scraping the top of the rash off or the lesion, not the whole thing, and then just remove, and then sending it to pathology to examine it. Okay. I don't often do these because then I'm leaving some of the lesion behind, and I kind of like just to remove the whole lesion if possible. Punch biopsy, again, that's the top right image. It looks like a potato sputter, and you freeze the area, and you just take a little plug. So you turn that device into the skin. It takes a little core biopsy of it, or a punch biopsy, and you send it off. Often that needs a couple of stitches to bring it back together, which you can see in the lower image there. So that round hole is left, and we typically stitch that up. Excisional biopsy, we just go right around the whole lesion, no matter how big it is, and we send the whole thing to pathology for examination. Okay, so typically we'll do this sterilely. We'll clean the skin well, we'll prep the skin to avoid infection, and then really the complications are minimal. Sure, it could get infected, or it can bleed and ooze. Okay, but typically that's not a big issue. Infection is always a risk factor when you puncture the skin. Okay, so I think this slide is pretty clear, pre-procedural, in terms of we always use universal precautions, right? So when we're taking biopsies of skin, we're definitely wearing gloves. Sometimes we'll wear goggles. We'll drape ourselves just to make sure that if blood spurts out, or we're protected. Okay, so usually a sterile procedure. Intraprocedural, well, if we're taking swabs, we could take specimens, whether for bacterial or viral specimens. Remember, we need to express material In the case of bacteria, pus. In the case of a viral, the liquid that's in the vesicle. Okay. And then we take it with the Q-tip, and then we put it um, into the culture media, and send it off. Okay. I don't think I'll spend any more time on this slide. We'll just keep on going. Okay, so let's just talk about the general management of dermatological conditions. Okay, so this is more of a in general terms, and then we'll move on to some specific skin conditions. Okay, so in terms of wound care, whenever you have a wound, you want to eliminate the pressure from the area. Otherwise, you're going to limit blood supply to the area. So you don't want on tight bandages that are going to stop the blood supply to the area, because that's what's going to heal it, right? Making sure, especially with someone with a chronic wound, proper nutrition and good hydration. So the nutrition is going to supply the building blocks to heal the wound, and hydration is going to keep the blood flowing properly to the area. We often get wound consultants to look at chronic wounds, okay, because they'll follow them and treat them appropriately going forward, okay. We typically try to keep the area dry, right? We don't want moist skin all around wounds. Otherwise, what happens is the skin gets all macerated, which is basically that bathtub look. Once you've been in the bathtub too long, your skin's all white. And we try to avoid that because that really stops proper wound healing. Making sure the wound is kept clean is really important, especially if it's an open wound for sure. So changing wound dressings, it just depends, right? If you have a wound dressing that's oozing a lot, it might need to be changed 2 or 3 times a day. If it's a dressing that's kept clean, there's not a lot of drainage on it, then it may need to be changed once a day or once every 2 days. So it just depends, right? And some wounds are extremely painful to undergo a wound dressing, and some patients need analgesics, right? What else? So we spoke about diet just in terms of maintaining proper nutrition. Vitamin C is really important because vitamin C is involved in proper synthesis of collagen, which is in the tissue, right? So it wouldn't be possible to go into all the dressings. There's hundreds of types of dressings. And typically you just learn that as you're going along with dressing changes because there's new dressings coming out all the time, okay? The dressings that existed 25 years ago for me, many of them don't exist anymore, but many new ones exist, okay? Okay, so let's just talk about 2 different terms here first. So dehiscence just means that the wound has opened. Okay, so say the image on the left there, it was sutured. Actually, you can see some sutures at the top and bottom. And then the sutures broke in the middle and it dehisced. And it exposed the underlying subcutaneous tissue and maybe even down to the muscle. Okay, that's just dehiscence. Evisceration, that's not so good. That's worse. That means that contents within the cavity have eviscerated outside of the cavity, and we're typically talking about bowel, such as small intestine, that's eviscerated through an opening of a wound. Okay, this is not good, right? Because that's usually a sterile environment. Okay, so this becomes an emergency because now intestines that are typically in a sterile environment are exposed to the outside world. Okay, so what causes evisceration? So evisceration could be post-operatively where the sutures have just let go. So they broke open and the whole wound just opened up. It didn't only dehisce, but the contents inside eviscerated, right? So weak sutures or broken sutures. An infection in the wound, right? So an infected wound is not going to heal. The body's not going to heal it with an infection. So that can result in dehiscence and potentially evisceration. Okay. Forceful coughing. You're putting too much pressure on the wound. You're lifting something when you were told not to. That's going to increase intra-abdominal pressure, put more force on the stitches or staples, and potentially rip them open. And then someone can be left with dehiscence or evisceration. Okay. What are the symptoms? Well, definitely pain if the wound opens. Bleeding can occur because it's torn through vessels that we're trying to heal. Vomiting can occur if bowel comes out and twists and gets obstructed. So if you had an evisceration and the small intestine kind of oozed out and twisted, sure, you get a bowel obstruction and you'd be vomiting. Okay. Some people can, especially people that are significantly overweight, abdominal binders. So you can get these Velcro binders that go around your abdomen and hold the contents with more force. Okay. Now, if this was to occur in hospital, we would definitely not have the patient sitting upright. It's going to put more pressure on the abdomen. So we'd lie them supine. We'd cover the area, especially with an evisceration, by the way. We'd cover it with just moistened sterile dressings. And then the surgeon needs to be notified because this needs to go back to the operating room. Okay, so supine position, cover with sterile dressings, and notify the provider because this is heading back to the operating room. This whole area would need to be cleaned, flushed properly, and reinserted into the abdominal cavity with an evisceration. Okay. Okay, so vacuum assisted closure for wounds. So this is typically in chronic wounds, but they're not infected, right? So the idea behind this is you want to provide, this machine's going to provide some negative pressure, okay? So it's placed into the wound, provides negative pressure, which in essence is going to bring more blood supply to the area. It's going to suck out any exudate or any excessive fluid, and it's going to allow the formation of granulation tissue, which is normal healing tissue. That's what you want, right? We want granulation tissue. So it does a lot of the things that wound healing does, right? Removes excess fluid, perfect. Increases blood flow, very nice, and promotes formation of granulation tissue. So these vacuum assisted closure devices can be very useful in non-healing chronic wounds. Okay, let's look at some different names for drains. So drains are often put in post-surgical or during surgery and left in post-surgical so that fluid has a way of escaping. Okay. Otherwise, what's going to happen if a drain isn't put in is the fluid is going to accumulate in the tissue and have no way of getting out. And it's going to form a collection of fluid called a seroma. Okay. Or if it's bleeding, it's going to form a hematoma. Okay. Okay. So let's look at a couple here. So the idea of these drains is to allow fluid to drain out. And by doing that, you don't have fluid sitting in the wound, which is going to put the patient at risk for developing an infection, right? And it takes the pressure off of the whole area because you're getting rid of the fluid that's in the wound. Okay, so let's look at a couple. So top left, Jackson Pratt. Okay, so this is likely from post breast surgery, and a Jackson Pratt drain is put in. So that drain just goes into the area where the surgery was performed, under the skin, and the body loves to put fluid into areas where surgery has occurred. And this drain is going to go to a bulb. So the bulb is, before it's attached to the drain, the bulb is pressed in, and then it's attached to the drain, and it provides negative pressure. so that it gives a bit of suction to pull more fluid out. And that's a Jackson Pratt. And once the bulb fills with fluid, it's drained, it's pressed in again, and reattached. Okay. A hemovac, same idea, right? What's the hemovac? Just a drain that's attached to a device where you can press in and seal it, and then when you let it go, it provides some negative pressure to the wound and pulls the fluid out. So that's lower left. On the right is just a Penrose drain. So this person had hand surgery, and there's a drain that's just following the tissue underneath the surgery because they know fluid is going to collect there. And if you look at the fourth finger or digit, you can see the Penrose drain is sticking out there a bit, and on the other side. And when it's done with, when it's not draining anymore, it can be pulled out. Okay, so it's not going to be months later, it's just going to be days until the drainage stops, and then the drain can be pulled. Okay. Now, with significant drainage, such as from the top left, so say from a mastectomy or breast surgery, we always want to know the amount of fluid that's draining out, right? So input and outputs for sure. The color is important. Is it draining blood or is it just draining nice serous fluid? Okay. So serous fluid is yellow. Serosanguinous fluid is kind of like what you're seeing in the top left bulb there. It's reddish. Looks a bit like Kool-Aid. It's got a bit of blood and a bit of, it's mixed with yellow serous fluid. Not infected though. And then of course frank blood, such as in the bottom left. That looks pretty frank blood, right? From that hemovac. So it's kind of a range from serous fluid, yellow, serosanguinous, kind of yellowish, pinkish, not too concerning. Frank blood, kind of want to let someone know because they may be losing a lot of blood. Or if there's pus coming out, if it's coming out yellow or white, that's not good either. That means there's a wound infection in there.